Right. So tonight we're joined by the representatives of Overlake, and this is something that you all as a board have been looking forward to, the opportunity to actually meet the faces that go with the names that you hear us say. So just a great opportunity to understand who they are, who Overlake is, as well as some understanding around motivations. As we talked about before, this probably isn't the right forum to jump in and discuss negotiation items and terms, but great opportunity to just learn more about where we are and where they are. So probably I know everybody shook hands. Probably a great thing to do is just to go around the room and offer introductions who each person is, if you're okay with that.
I think that's an excellent idea.
Start it wherever you want.
Okay, I'll start with me. We'll go around the table this way. I think you already know Steve, and then I don't know if all you do, and then you can introduce yourselves as well.
Sure.
Okay. I'm Daryl Norris, and I live in Preston. This is just down the road, and I've been the president for 4 years now, I think.
I'm Emma Heron, and this is my fourth year, and I live in Snoqualmie Valley since 2000.
David Spikers. I've been a board member for going on 13 years, and I've seen bad and good. So anyway.
Gene Pollard, 7 years on the board in 2 elections. And I live in Snoqualmie. Been here about 35 years now. And I want to welcome you to come to our meeting.
Steve Daniel, District CFO.
John Duarte, Chief Strategy Officer. I've been at Overlake for about 5 years in April. I recently was promoted to this role in December, having served as Director of Strategy at Overlake, and have been in work for both hospitals and then also as a consultant for a number of years.
Hi, Dave Knopfler. I am almost an original East Side person. I moved there in the late 60s at age 8, and have lived in Bellevue, Sammamish, Seattle. Never further east than Sammamish-Issaquah, though I didn't quite make that here. I've been at Overlake working on 27 years, actually. So 5 years almost in my current role as Chief Medical Officer.
A little bit of laryngitis, but Andrew Tokar, the Chief Financial Officer for Overlake Hospital. I've been at Overlake for coming on very close to 17 years. I've been in the CFO role now a little over a year. I was the Director of Finance for a number of years prior to that.
Rob Campbell, I'm a Seattle native, live in Kenmore. I'm a board member, been on the board for 9 years. I chair the strategy committee, serve on the governance compensation committees. Also, I'm on the board of a partnership we have with Evergreen, Eastside Health Alliance, and serve as the chair of that. I've served on the chair as the chair for the last, say, year and a half or so. My career, I retired about 4 years ago. My career was in finance and with retail and restaurant companies. The last 17 years I was with a little shoe store called Nordstrom.
Well, good evening, and thank you very much for inviting us. We were talking to Emma on the way up about putting a name with a face, and that always helps. And I really appreciate the opportunity to be here with you tonight and get to hear a little more from you and have you hear from us and have a conversation. So I'm Mike Marsh. I've had the privilege of being the CEO at Overlake for 5 years. I'm just about to hit my 5-year anniversary. I've been in healthcare leadership for over 30 years. I really consider it to be a very special privilege to have been in roles where I can be leading organizations or parts of organizations who care for people at the most vulnerable times of their lives. I like to say to our new employees, to some people, healthcare is a job, to some people it's a career, and to some people it's a calling. And I know that for myself, it's definitely the latter, and feel very honored to have spent my kind of a one-trick pony, spent my entire career in healthcare, and have been privileged to do so. So with that, Kim, I don't know if you'd like me to provide any opening remarks about Overlake and just orientation, or how you'd like to.
Please just jump right ahead. Okay. I think everybody's interested in understanding who Overlake is, some insight into quality, some of the things you all have going on.
Sure.
You've got a big building project going on.
Yeah.
So before we do that, How many of the board members have been or used Overlake services?
Oh,
I used to work
my
there
family
and,
still go there.
yeah. Okay.
So you all have some familiarity with Overlake. Maybe just to make sure that there aren't little fun facts that you don't know about, I'll cover some territory that maybe you already know. And I'm going to ask my colleagues to jump in, and we'll do this. If there's anything that you want to add, feel free to add. I like to say that Overlake was built for the community and by the community. It's a nonprofit, 501c3. We were formed in 1960, which I like to say is 2 years before their CEO was formed, which gives you some idea of when I was born. And as the East Side has grown, Overlake has grown. And so for those of you who've lived on the East Side for a long time, you know Overlake was a relatively small facility. We've grown to be, as measured by admissions, inpatient admissions. There's a lot of ways you can measure the size of an organization, but as measured by admissions, we're now the 5th largest hospital in the state, which is not surprising when you think about the growth that's occurred throughout the East Side. We have about 3,000 employees. We have just about 900 physicians active on our medical staff. We see ourselves as serving the entire East Side. And we define the East Side really from Renton to the mountains to the lake and to north of Kirkland. And so where we put clinics and have expanded our footprint has been not just in the greater Bellevue area, but throughout the East Side. We're known as what's known as a tertiary hospital. And so we provide advanced services such as cardiac surgeries, electrophysiology procedures, thoracic surgeries, neurosurgical procedures. We have a level 3 NICU, which is the highest level of neonatal intensive care unit that you can have. We have a comprehensive cancer center. Really proud to say that Overlake has, since its beginning in 1960, dedicated itself to caring for behavioral health patients. We've had a psych unit, which a lot of hospitals have closed over time, and there's a huge need, of course, for behavioral health. As the community has grown of the East Side, Overlake has seen it always as part of its mission to grow with it. We are a very financially strong hospital. We have a very strong balance sheet. Kim mentioned our construction project, which I'll speak to in a little bit, but just some indication of our financial strength is when we went for our bond offering, we oversold our subscription by 5 times in a time when 2 other health systems were in the market and didn't receive a full subscription. We're an A-rated organization. Our days in cash are about 360. So those of you who know hospitals, even relatively healthy hospitals, would have days of cash of 120 to 140 range. So it gives us the capacity to think beyond next quarter and really to think into the next quarter century when you have that type of a balance sheet. We just had our A rating upheld by S&P 2 weeks ago, I think it was, and that was another strong indication that the market continues to recognize that we're in a great community, the East Side, where it's growing, it's vibrant, that we've got a good track record of executing on our plans, and we've got good plans. So one of the things that I'm most proud of is our commitment to quality and patient safety. So in my 30 plus years of working in healthcare, most of that time, if you did more, you did better, right? It's the fee-for-service environment. Volume was king. In an environment where we're transitioning to value-based contracts or pay for performance, if you do better, in other words, better patient care, higher quality, you do more. When I first started, even 5 years ago at Overlake, very few of our contracts had any value-based component in them whatsoever. And now, probably almost all of our contracts have some form of value built into them. So what does that mean? Well, it didn't really start with the government. It really started with private industry in the early 2000s with a group called Leapfrog. So I don't know if you've heard of Leapfrog, but Leapfrog was a group of Fortune 500 companies that got together and said healthcare costs too much and it's not reliable from organization to organization. we want to build a composite across multiple dimensions: safety, quality, experience, patient experience, and efficiency, which is usually cost. And we want to find the best hospitals in the country that we can start steering our patients towards, because they were getting inconsistent experiences for their employees, and healthcare escalation was just going up and up and up and up. So they created this rating system across an objective composite where they rate all hospitals in the country. And they rate you from an A to an F, just like when you were in school. And I'm very proud of our Overlake team. You get measured twice a year. And so in the last 13 reporting cycles, we've had 12 of our 13 reporting cycles, we've had an A grade from Leapfrog. The CEO of Leapfrog called us out recently in a publication, specifically Overlake, with respect to how remarkable that accomplishment is. So then you roll forward a few years with Medicare, and Medicare has now implemented value-based purchasing. So now it happens to be based on the same dimensions: patient safety, clinical quality, patient experience, and efficiency. And they measure you based on your performance across a pretty vast composite of indicators. And this is a much newer program. It doesn't date back to the early 2000s. It really only dates back for like the last 5-ish years. And we've been the #1 large hospital in the Puget Sound 5 out of the last 7 years. And we've been the #1 hospital in the state multiple times in that same period of time. Large hospital, I should say large hospital, because the indicators are slightly measured differently depending on what scale you are. And I can define what large is if you're interested. But this last reporting period, which was given to us in just a few months ago, we outperformed the national average by twice. These are composited numbers, and the state average by twice. What did that mean? It actually means, again, we were #1 in the Puget Sound. We were, for large hospitals, we were #1 in the state. And then in the country, we were #5 out of 980 large hospitals in the country. So, you know.
Now, is that by CMS? Or
That's CMS, yep. Mm-hmm. Yep.
I just read their report, and I listened to the fact that latest report.
You might be thinking of the star ratings. So the star ratings
I am thinking of star ratings.
That's a different measurement. That's more consumer facing. The CMS value-based purchasing program is more industry-facing in the sense that our Medicare payment is based on how well we perform in that composite that I spoke to, and they're measured slightly differently. The CMS star ratings especially tend to, and CMS is under a lot of scrutiny right now for those star ratings, tends to penalize the more complex organizations that have higher acuities. So like universities don't tend to do well in star ratings because they have a lot of acuity. But they are two different things. So I think we are either, I think we're 4-star at this time. So people talk a lot about Overlake. So our nonprofit mission is very important to us. When we look at, people think, well, you're in Bellevue, you don't have any poor people. It's not true. We are actually what's known as a disproportionate share hospital. A disproportionate share hospital means that you have a certain level of uncompensated and undercompensated care. It's a very important part of our mission to care for the people who are homeless or who are incapable of caring for themselves at the same level that some more affluent with the same level of care and technology and attention that we would have. Maybe I'll give you an example of that. We had a woman who came into that she was living with her daughter in her car in Bellevue. So a mom and her daughter. The daughter was an adult. They're both adults, and the mom was experiencing symptoms of having a heart attack. And so her daughter drove her to the Overlake ED. Sure enough, she was having a heart attack. They immediately brought her in, and we did open heart surgery on her and did a coronary bypass on her. She did very successful. This was totally uncompensated care. But then we didn't have any, and she was great surgery, great outcome. Didn't have anywhere to discharge her because we couldn't discharge her to recover in the car. So we put her up in one of the hotels for about 3 weeks until she could adequately recover and unfortunately, go back to a homeless lifestyle. But I mention that because a lot of people don't really understand. There are a lot of people that don't even know that Overlake's a nonprofit hospital. And when you look at our charity amount of charity care and compare it to even some of the downtown hospitals, in fact, we just saw this morning with our accountants, our percentage of charity care equals those of the downtown hospitals. So that's an important part of our story too, is that we care for those that aren't just those that are wealthy. We really have tried to create a culture that is very values driven. Our values are integrity, compassion, agility, and respect and engagement. So those are our values. We build those into our rewards and recognition program. 3 years ago, we were recognized by the Healthcare Advisory, which is, basically is an organization that it's one of the major organizations that does employee engagement surveys. I don't know who you use for your employee engagement survey, but we were in top 5% in the country for employee engagement. That was 3 years ago, just in spirit of full disclosure. And then 2 years ago, or it was either 2 years ago or last year, we were recognized by Seattle Magazine as a best place to work, and we were the only healthcare organization in the entire Puget Sound to get that recognition. And my intent is not to be boasting or giving you any impression that I want to give you the wrong impression that we don't have things that we can work on, because we always have things that we can work on. We do continue to grow our ambulatory network. My time at Overlake, 5 short years, we've increased our investment in our ambulatory network, our clinics, out in the surrounding areas, from $22 million a year to $44 million a year. I should say we're a $500 million company just in terms of the size of our operating base. So our clinics have become a much more important part of what we have historically done. So we're not just a hospital, we're a health system. Partnerships are important to us. Rob talked about the fact that he chairs our Eastside Health Alliance with Evergreen. I think probably many of you who've been around the East Side for a long time know that Evergreen and Overlake have been fierce competitors for a long time. And somebody said to me, if you could create a relationship with Evergreen, then maybe we'll get you working on peace in the Middle East next, because there have been a lot of false starts, over the years between the two organizations. And we've done 2 things that are really notable. One is we integrated our cardiac program. And so Evergreen had a relationship with VM, and they were sending their cardiac, Evergreen does not have a cardiac, Evergreen's a great hospital, they don't have a cardiac surgery program, and they don't have an electrophysiology program. They're not quite as advanced in their cardiac services as we are. So they were sending those procedures and their thoracic procedures downtown in their relationship with VM. We integrated our program, and now patients who lived on the East Side, who are part of the Evergreen network, who are traveling downtown for their care, now can stay on the East Side. So we've repatriated about 100 open hearts, about 200 EP procedures, or electrophysiology procedures, and about 100 thoracic procedures. So these are people that are getting their care closer to home. We've also formed something called the Eastside Health Network. And the Eastside Health Network is a clinically integrated network. A clinically integrated network is a legal term. CIN is what they call it. Kim is actually on our Eastside Health Network board. That was important, and I'll speak to that in a second. But we formed this network for the purposes of contracting with payers, going direct to business, because increasingly health plans, employers are looking at self-insuring. Self-insured levels used to be at levels of, you need to be over 5,000 to self-insure, and the self-insured numbers are coming down and down and down because, frankly, the employers are looking at disintermediating the health plans in order to save money and doing direct business. This gives us the capacity to do that. So 2 things I want to point out about that. This network has 1,400 physicians in it. 1,400 physicians on the East Side. If you think about the amazing synergy that goes with 1,400 physicians, we have 16 members on our board for Eastside Health Network. 14 of them are physicians, and the majority of those physicians are independent physicians. So while both Evergreen and Overlake has employed physicians, we still support the independent physicians in ways that allows them to be viable, because otherwise it would be very difficult for these smaller practices to compete in this space of value-based purchasing against the scale of some of these very, very large initiatives. Overlake and Snoqualmie have had a good relationship for a long time. Our administrative teams have worked well together. Our medical staffs have worked well together. When we formed Overlake Provider Network, which was the precursor to the Eastside Health Network, one of the first things we did was invite Snoqualmie into our Overlake Provider Network. Kim's been part of the Overlake Provider Network, which was OPN. That then was succeeded by the Eastside Health Network. And then the best part of the Eastside Health Network that I'll end on relative to that part of the story is that really demonstrates the power of these networks in an environment where you're producing higher quality at lower cost. As Kim maybe has reported to you, the Eastside Health Network landed a contract with Microsoft. So Microsoft created a health product around the Eastside Health Network. And so just to put that in perspective, Microsoft only has 3 plans they offer their employees in the Puget Sound region and on the east side. Primera, which everybody knows, Kaiser, which is of course a big name, and our little Eastside Health Network. And they've named it the Health Connect plan. Not only did they approach us because of our quality and our cost scores, but they've made that plan their default plan. So if you become an employee at Microsoft and you go through open enrollment and you don't choose a plan, which a lot of these young Microsoft people, they didn't even think they're going to get sick, so they just go to bypass that part of it, you will default into the Health Connect plan. Well, Snoqualmie's part of that, and Snoqualmie's part of that because it's part of the Eastside Health Network, and it's part of the Eastside Health Network because we really felt that it was an important partner to be connected. So I'll stop there. So you want to add anything to what I said that I maybe didn't touch upon?
I would say, I'm just, because I'm here. It seems to me, having lived in the Valley 45 years, and having worked at Harborview, having worked at Overlake, the one thing that's going to change even more than it has in that length of time is transportation. Yeah. And how easy it is to get to a good healthcare system should you have a serious issue. And I know we have Swedish in the background, but I think Overlake for this community has been the closest for so many years that for this community, that's the natural place for many of them to go just because it has been here longer than anybody else. And with the transportation issues and having to go into Seattle, that just becomes less and less desirable and then even more difficult. Even if you're in an ambulance, it's difficult.
Yeah.
You know, Medic 1 still has to stand in line sometimes with all the other cars. So for me, that makes it a practical, not just good health care, but it also is practical. If you can't get to a hospital, then you might as well forget about what kind of health care you're going to get.
I think the scope of services is really important too. You know,
I think you're right.
Puget Sound is, I think, blessed with an abundance of riches in the sense that I would say that all of our health care systems are strong providers. I would say that though, you know, because we're a tertiary hospital and we do have such a large level of sophisticated services that you couldn't find at a community hospital, and that also makes a difference. Transportation is, you know, increasingly becoming a very significant issue. We're one of only, from an employee standpoint, we'll be one of only 2 hospitals in the Puget Sound that's on the Sound Transit line. So the other one's University of Washington. The Sound Transit line will be stopping right in front of Overlake, essentially, will be really nice. I didn't mention our Project Future Care, which is, have any of you driven past the campus recently and seen that it's all torn up? And, yeah.
Are you going in your second or third phase now?
Well, this is, we've dubbed this project Project Future Care. It's a $250 million project. And it is, it consists of, we just finished a new cancer center.
Yeah.
So we finished, the cancer center was a $20 million cancer center, and that was finished, and then we rolled into Project Future Care in tow. It consists of 2 new cardiac ORs, one of which will be a hybrid room, which will be a nice advancement for our cardiac and vascular services. We do a lot of what's called transaortic valve replacement. These are minimally invasive valve replacements. We are one of the first 4 hospitals in the state doing these transaortic valve replacements. Those will be done in the hybrid room. We're growing our cardiac program pretty significantly, so we felt like we needed to expand that. The centerpiece of our Cardiac Future Care is our new tower, our new East Tower. It's a 240,000 square foot tower. The centerpiece of it is a new childbirth center. Really our first connection with the population's changing so much, is those new families, those families that are having babies, and with a level 3 NICU, that's important. We'll then be building a new medical floor and a new surgical floor, and we'll be demolishing one of our older buildings on campus to create a marquee entrance that makes wayfinding easier. Overlake's kind of a confusing place to get around sometimes. And then the old childbirth center, if you know where that is, on the top of the garage.
Yes.
Which is a little strange, but we are, after we move the childbirth center into the new building, that will be where our psych hospital is. So we'll be able to expand the footprint of our psychiatric services, larger spaces, larger community rooms, and really create, continue the commitment to serving that population. The project's going very well. We're 2 years into it. When we started it, we took on a challenge, and we said, we're not going to use this as an excuse to allow our patient experience to deteriorate. Because it'd be really easy to do that, right? It'd be really easy to say, holy smokes, we've torn up our campus. Of course, people are going to have a hard time finding their way. Of course, it's going to be noisy, yada, yada, yada. We said we're not going to let that be an excuse. And I'm really proud to report that last year, we not only didn't deteriorate our patient experience scores, we improved our patient experience scores. In fact, patients now are requesting to be on the construction side of the building so they can watch the construction.
Not because they get a discount.
Yeah.
Mr. Marsh, one of the things, you mentioned a lot of the different services. One of the things, I don't know if you probably have already said about, is what orthopedic services.
Yeah.
Is that something
That's
that,
a big, thanks.
because our community here, as I mentioned earlier, really has such a mixed population. You have the elderly, retirees, and then you have young families. So I'm just curious.
No, that's a great question, and it actually reminded me to offer a couple of other points that are related to percentages, and I'll get to the orthopedics, but I want to get these two off my mind before I forget. Kaiser is a strong partner of ours too. We're the exclusive partner with Kaiser. About 20% of our business is Kaiser business, and Kaiser's growing substantially since they've taken over group health. They really are making good on their pledge. And the other statistic I wanted to share is we're up to about 20% of our business now is from outside of the East Side. So while I talk about the 900,000 people on the East Side as our primary market and where most of our emphasis is, because we do provide such a high level of service, we about 20%. Now, to your question on orthopedics, also, how much percentage of our business is orthopedics?
What percentage? We do about 1,600 joint replacement surgeries a year, which is one of the top in terms of volume in the state. To about 2,500 total orthopedic admissions. So, a good close to 20%.
Yeah.
Right there. Yeah.
So orthopedics is which is a good thing and a bad thing. I mean, it's good because we are very strong in this service line. We've been recognized by multiple organizations as a top tier performer in orthopedics. But anytime you have a service line that's that dominant in your portfolio, it can make you vulnerable too. Yeah. And so as we think about our strategies relative to maintaining our long vision, we're always looking at how do we keep the switching costs as high as possible in order to be successful in continuing to exceed the expectations of both the physicians and the patients that we serve.
Would you consider putting that in your project Future Care?
Well, we do. So orthopedics. There will be an orthopedic unit on the 5th floor of our new East Tower. So currently, our orthopedic unit it's primarily on the 3rd floor of the old East Tower, and it will move to the new building. So it is part of our project Future Care. You know, our childbirth rooms are going to be 60% larger than they are now. And I think our labor and delivery are like 100% bigger than they are now. They're substantially bigger. And part of the reason for that is that there's a term in obstetrics or childbirth centers called family friendly. And that sounds kind of like a slogan, but it's actually a designation that a lot of hospitals will use that essentially says, if the parents want you in the room and it's safe to be there, you can have as many people in the room as you want. Well, when Overlake built its facility, you know, its old childbirth center, the rooms were perfectly adequately sized. But now, especially with a lot of first generation Americans coming from other countries that have a very large family orientation, and especially the South Asian population, they bring a lot of people to these childbirth experiences. And that was really a big driver for the whole thing, is trying to maintain the need for that family environment to be in the child.
My 2 grandkids were born in Overlake, so.
Yeah.
I have to tell you, that's a
great.
an interesting experience, because my daughter recently delivered and she was up in Everett, and all the people that stayed there for hours, and I'm thinking, when I did this, it was just my husband and I'm not sure I like all these people around. But it is a real family type thing, so that's interesting that you're doing that, because that's what the environment, she was a smaller room, but it was an environment where she had uncles, aunts, everybody in that room. I think at one time, to get delivery going, the midwife finally went in and said, "You all need to leave because this baby needs to be born." But it's interesting. I think that's the trend.
Yeah.
Definitely.
I've got a few questions for folks.
Your turn.
All right, thank you. Andrew, what's the percentage of charity care and self-care or self-pay that you have right now?
So right now, charity care, as a percentage of gross, I think it's running right at about 2-3%, but on a raw basis, it's like in the 20 million range, if I recall.
What's the percentage of your gross income, gross revenues?
Meaning?
What's the percentage of your billing? Charity care and self-pay.
Let me take 20 million. I mean, God, I guess that would be off a net of 500 million. So it'd be 20 million off of 500 million. You know, so pretty significant, I would say. What's that, 8?
Probably about 4%.
Yeah, 4%. Yeah.
Okay. Jonathan, you've been a strategist for quite some time, and how do you perceive the state of politics with respect to Obamacare and reimbursement? I know that
I need to check CNN online.
It's changed.
It changed
like 2 days ago, right?
So, what is Overlake doing to protect itself, so to speak, under new policies and that kind of thing?
Well, I think we all can't predict the future on that one. Mm-hmm. And you know, when I was joking, but you know, if you all have checked the news, I mean, you do know that they, you know, the DOJ looked at, you know, basically looking to strike down Obamacare, or you know, the Affordable Care Act. So you know, from our perspective, you know, we have risk, of course, around some of those products that, you know, and what that happens to that. And so I just think we, you know, as a percentage of our total revenue, it's fairly small compared to others. So I think it's $3 million or something of our revenue. But I think we focus on the growth in the community and serving the community and its needs. We look at expanding our clinic footprint, the specialties that we offer, and just ensuring that we're meeting the needs of the community at large. You know, you can kind of chase that, you know, chasing the wind a little bit on some of that, I think, but we just kind of focus on our core fundamentals of providing care every day to our patients, you know, ensuring high quality, reliability, and ensuring that we're meeting the needs of the growing population and changing population.
Okay.
You know, I'm going to add a little bit. Just, I think when the ACA originally got up and going, there was some question on all our parts about what would this do? I mean, it was a big mystery, and we did see a significant decline in the folks who basically were private pay, i.e., no insurance. And in the end, I mean, from a bottom line standpoint, it was a win. I mean, we had patients who previously had no health care insurance at all who got it. And, you know, it led them to come in and get the care that they actually needed, and not develop more serious problems that then would be even worse down the road. So, you know, just if you looked at it purely from a financial standpoint, it increased the revenue. If you looked at it from the standpoint of the patients receiving the care they need, they did.
I think also regardless of kind of what happens with the law, I mean, EHN, I think the Affordable Care Act jump-started a lot of these value-based care things that Mike spoke to. And I think, you know, as we see the momentum that's created, we don't see that changing because payers are, and employers are still going to be looking for high quality, high value. And focusing on that is how we see, you know, sustainability and growth in the future. And I think any of that, the ball's been already put in motion, and people are seeing what you get when you truly look at the value of your health care. And it's better than what we had, you know, a lot of the tools that are available to assess that, et cetera. So we see that continuing and emphasizing that EHN and our value-based competencies to be able to meet the needs of the employers and patients.
Okay. That's what I would have expected, I would think, but I guess that's a good answer. I got another question, this time for Bob. How do you see this potential affiliation? Rob. I'm sorry, Rob.
That's all right.
Sorry.
How do you see this potential affiliate? It's a potential.
Yeah.
How do you perceive it as a win for Overlake and a win for the community here? How do you perceive that? Being in finance background and being on the board for 9 years, did you say?
Yeah. I mean, there's a financial lens that is appropriate, but that's not the lens really that I do it from. And I think I can speak for the board on this, where there is alignment across every board member is how can we serve the healthcare needs of the Eastside community better? And that would encompass Overlake, and I bet you I would find agreement with every person that's in this room tonight. And so I think the potential win is we talk about, and it's aspirational, providing a seamless experience, something that is this isn't a good word to say painless, but is as patient-friendly as possible. And one of the ways we think we can serve the community better is by expanding our presence and making ourselves more accessible. So we think in partnership with Snoqualmie Valley, there's the potential. It's not easy. There's potential for us to work well together to collectively serve the residents of this community better through the shared services that we have. It's been, in our partnership with Evergreen, we found that whether it's through cardiac, quality, the sharing of information, we're making each other better. And we think there's that opportunity here as well.
Thank you.
You're in a different position than we are, and that is that our residents of the hospital district pay taxes to the hospital. In your catchment basis, the people there pay no taxes to support your hospital. And so one of the things that we've got to do is convince the people of the hospital district that this is a good deal for them. And that won't be easy to do, very frankly. So we need to articulate the advantages of a merger or affiliation and make it clear to the taxpayers, or they will be taxpayers without representation, they'll feel. They'll feel that we sold them out. So we need to very clearly analyze and articulate exactly what the benefits are. I have a couple of questions. One is, while you are a 501c3 organization, you're a private hospital. Now, you've been welcome to our board meeting tonight, but what would you say if we wanted to come to your board meeting? My understanding is your board meetings are not open. Is that correct?
They're not formally open, no. But we have guests join us on a regular basis, but no, they're not formally open.
So that's one difference in culture between us. And I think in the due diligence, we have to see whether our different cultures are going to be in a position to mesh. And if not, then as part of due diligence, we have to say maybe this is not for us.
Yeah. Can I just say one other thing? I think that, Evergreen, of course, is also a district hospital, and we had a lot of those same kind of conversations. And with the Evergreen relationship, it wasn't as much of us taking over management control, which is what we're talking about in this situation, as it is a joint venture. But it was so that culture thing was even more pronounced because you're coming together as two equals around a particular topic. And of course, they have all the same requirements that your district has in terms of being a public hospital district. And we've not found that that has been a barrier at all to our capacity to work together from board to board, and our ability to be transparent in our dialogues about our planning. Now, I will say that, Evergreen does, they do have 3 of their 7 commissioners who participate on the EHA board, so it doesn't trigger the public record, or not records, but public requirement.
Open public
meetings
and open public records and so forth.
But my only point is that we have one very real and very near-term example of working with a district hospital, and your points are well taken, because the district hospital and your accountability to your constituents and stakeholders is important. I will say that when Tom was here, Tom Parker, and we were talking about this phase, this round, if you will, I said, one of the things that I think we should do is town halls. As we get further into the process, have a few town halls where members could come and ask us questions, ask me questions, ask the team questions, not that like we're having right now.
I think that's an excellent idea. And then going back to Commissioner Pollard's concern about our fiduciary duty to our taxpayers, and your comment, Mr. Campbell, that your presence is very important to do this community outreach and within this new partnership. And I think my own perception, there won't be any high roads to cross, because Overlake is very well known. Not to discount the other districts like the Carnation and the Falls City and our other communities that's within our district. Overlake has a name, and when we first started this, the main concern was branding. Mm-hmm. So that's why I thought, let's look at all these hospitals and see and listen to the people that live in the district and see what they think. And many of the people that I've listened to were looking at, well, I hope those are the comments that I hear about Overlake. We didn't look at Swedish, but there were several different RFPs that went out to different health hospitals. So that's just my comment, and just alluding to Mr. Pollard's concern about our fiduciary duty to the taxpayer. And town halls is an excellent idea to bring hopefully everyone on the table and ask point questions.
And that framework, very important. I'm glad you pointed that out. The point is that if the people feel that they haven't been participants in this process, and they don't understand it, and we have not made a good case to them, they just won't come to our hospital. You got to realize that Swedish is 9.5 miles from this hospital, and I think that's closer than Evergreen is to yours, if I'm not mistaken.
They're probably about the same, but they're close. It's close. Yeah.
So I guess what I'm saying is we could come up with all the beautiful legal documents, but if the people are not convinced in our hospital district, continue coming here or start coming here, they just won't come. So we've got to do a good job of this, or else it's going to cost us all. But I have an overriding question, and that is, in the United States, we're spending about 18.5% of our GDP on healthcare, which is about double most other advanced industrialized nations.
Very true.
This is not sustainable.
Very true.
What do you, from your perspective, with so much experience and overview, what do you suggest to get us out of this pickle?
Well, man, you need to pay me more for that. You need to pay me more money for that question. No, it's not.
You don't have your crystal ball.
Yeah. Well, actually, I love questions like this because I actually love healthcare policy and have spent a lot of time with healthcare policy. Your statistics are accurate. And then when I entered my healthcare career, which is in the mid '80s, healthcare was about 12% of the GDP. So again, as I said in my remarks, many of our businesses and employers say it costs too much and it's not consistent, it's not reliable. So that's why when I made my comments about value-based purchasing and our performance, it's so important. So just a couple of things that I would say. First, if you look at the hospital industry by itself, and you can throw physicians in with that, so think of it as health systems, we have, over the last 10 years, bent the healthcare cost curve. So we bent the healthcare cost curve. If you add in drug companies, we haven't. So it's really, and I'm not throwing the drug companies under the bus because the technology that's coming out of the pharmaceutical industry is remarkable. But if you look at how healthcare cost inflation has been most dramatically impacted in the last 10 years, it's not specifically the health systems as much as it has been the drug companies. So part of the solution is to have a better answer than anybody has brought forward from a policy level on how to curb the cost inflation related to drugs. The second thing is I do think pay for performance or value-based purchase, they all have different terms, but they're basically the same thing, is a good thing. I mean, the concept that you should have a clinically reliable product, I won't name names, but, we have better outcomes in many service lines, but I'll use, since Emma brought this up, orthopedics, than some other hospitals in the Puget Sound for about 60% of the cost. So it sounds counterintuitive because in most industries, if you pay more, like let's say you pay more for a car, you'd expect to have a better car. In healthcare, it actually doesn't work that way. If you pay more, you don't necessarily have a better product. And the organizations that are producing the highest value, and the fact that we've been recognized by CMS in that scheme that I was talking about earlier as number one is evidence of that. VM's strong in that way too. Evergreen is strong. But other hospitals, and there are other hospitals, Central Washington, Wenatchee is a strong hospital. Central Washington is Confluence, that's another example of a single market health system that's doing quite well in this environment. So from our perspective, I think that when you are approaching 20% of the GDP, you will always be a budget target. You will always be a budget target. So there will never be a tall clover day in healthcare ever again, if there ever was one. We will always be fighting budgets, always, because at 20% of the GDP, we should be fighting budgets. But if you think about again, I don't want to name names because I'm being videotaped, but I will say that if you think about, there are other hospitals in the Puget Sound region. To get to our level of performance, we'll have to spend millions of dollars. And so our capacity to operate in a more cost-effective environment at a high quality gives us a competitive advantage. And so we feel that the requirements for others to get to where we're at will continue, the pressure will continue. We want to monetize our capacity to be successful through our relationships with employers, like this Microsoft contract. Again, remember, Microsoft came to us. We didn't come to Microsoft. That's a very big distinction. I can't even imagine without 1,400 physicians on the east side, Microsoft coming to Overlake or Evergreen separately. They came to us because we were together in a clinically integrated network. But it's a big, it's a huge issue. What you didn't say is not only are we more expensive, but we have worse access and poor quality as measured by most indications. We have a maldistribution. We have some of the best healthcare on earth in the United States, and then we have huge pockets of our population who don't have access to basic care. And that creates maldistribution that lowers the average of the quality that we receive.
Isn't
The
there?
World Health Organization, in terms of outcomes, puts us at number 37 next to Croatia.
Yeah.
So we're the most expensive,
Right.
and yet the outcomes are not that good. Now, that's not being hospital specific, that's the system we have.
But isn't some of that too the fact that physicians can be sued in the United States? There's a lot of money that happens, and in other countries they're not sued. That's not even allowed. You do not get to go after a physician.
That's certainly, there have been studies looking at it. It's not as big as you'd think. I mean,
Okay.
what it does more than the actual cost of the suit or the settlement is it changes the practice of the physician to be more defensive. Obviously, and there's articles about that on a consistent basis. And that's something we need to work on, absolutely. And, the talk is usually about tort reform. But, the reality is you need to get physicians back to doing what's best for the patient, being confident in their best practice standards that they're doing what's best for the patient. The thing I was going to add to Mike's comments, which fits in with this well, is preventive care, right? I mean, that, you look at Croatia and my wife is Polish and her family still lives in Poland. They get amazing preventive care. I mean, it is covered soup to nuts. You will get every medication you need, any blood pressure medicine for almost no cost. There's an upfront cost to that, but when you look downstream, and that's where I think in America we have a little more challenge looking past that initial hump, is how do you move some of that expense up, or expand to the front end to do with preventive care, and that fits into access. It fits, a little bit into our comment about the ACA as well, which is if you can get patients sooner, you prevent those really catastrophic complications, which are just incredibly expensive. So, yeah.
Do you think some of that has to do with lifestyle too? Americans' lifestyle as opposed to other countries like in Europe where they take all of the summer months off, like 2 or 3 months, and we're...
I want to believe that. Mike's going to give you the summers off now. So, but I think there is something to that. Although I think probably again everyone here is well read. You're seeing Europe, Japan, Asia lifestyles gradually move towards the American lifestyle, right? The American diet, and you're seeing all of those disease processes follow that pattern completely.
Well, there are social factors like childcare, for example, that we don't have much of compared with Europe.
Absolutely.
But I'd like to toss out a specific problem, and that is the opioid crisis. As you know, we're losing about 50,000 people a year in this country, which is more than we lost in the entire Vietnam War. What's the answer? And what is Overlake doing to combat?
Okay, I'm going to give this to Dr. Knopfler, but this is a great story. I'm really proud of what Overlake is doing. We are really putting a lot of energy on this topic and really leading the state in the work that we're doing with the Washington State Hospital Association. So with that intro, I'll turn it over to Dave.
So I'm gonna continue that in that we didn't just start this with all of the press recently. We started a couple of years ago through our emergency department, urgent care departments, looking at prescribing, and you can think of it a whole bunch of different ways. I mean, there's prevention in the sense of let's not get people initially addicted on opioids. So that's about setting realistic expectations for patients as to there is no such thing as zero pain, right? I mean, that's really the key. And so, let's touch on orthopedics. Well, you do now, instead of rehab, you do prehab, which is you bring people in and you say, you have a new joint in. It's going to hurt. We're not going to be able to get your pain to zero. But here's a reasonable goal. Here's a reasonable expectation. And here are all the other things you can do. Ice, heat, early mobilization. And, even though it hurts, we know that when you've got that new joint in, it's not going to collapse on you. When you're walking and it hurts that much, everything in your brain says, pain, stop, because something's wrong. When you have a surgery like that, you have to keep working with folks to get them to understand that pain is no longer telling you something's wrong. In fact, we know that you will get better faster. That's communication, that's the prehab process. You know, and you can throw in all sorts of other modalities. I mean, acupuncture, there's, you know, now topical creams that we use. We even do something in the orthopedic area where we infuse a local anesthetic directly into the joint that's had the replacement, and we watched our opiate use just drop like a rock when we do that. Patients go home with it. It's a little balloon that just sits there, and it runs out over about 2 days, but it keeps the whole joint numb, which means they can do a lot more walking. When it's done, they just pull it out and throw it away. It's not a controlled substance, but we see half the opioid use when folks have that. So there's a whole prevention piece, which is really important, which is about educating patients. I have to educate my providers. I mean, I'm a physician of the 90s, as Kim is, where we were told that you just give opiates till there's no more pain. We have to unlearn all of that as a profession. Having said that, there's people addicted. And the big miss over the last decade in particular has been not having adequate medication-assisted therapy. Going cold turkey, it doesn't work. I mean, there's like a 98% failure rate. It's just abysmal. I mean, we've probably had stories of folks who've been able to get off. That's extraordinarily rare. I mean, it's extraordinarily rare. There are now very effective medicines, and the one that most people have heard of and is in the news a lot is something called Suboxone, which is a once-daily medicine. It doesn't give you the high of an opiate, but it prevents the withdrawal. And most people who go back and use because they don't want to go through withdrawal symptoms. The state of Washington has now put in a lot of money, in the King County in particular, to set up clinics that administer this Suboxone.
Is that like naproxen?
No, Suboxone is actually a narcotic derivative, believe it or not. It's actually a distant relative of more like a morphine-like substance. However, when you take it, you don't get the elation, the high. You don't get that warm and fuzzy. What happens is you just don't withdraw. You don't go through the horrible withdrawal symptoms that people try so hard to avoid. And one of the challenges for physicians with Suboxone was that it was extraordinarily tightly controlled by the FDA. And you had to go through all sorts of special coursework. Now, what we can do in the emergency room is actually, if someone comes in and is clearly an opiate-dependent person, we can actually administer a dose to them there. You don't give them a prescription. You say, here, take this. You watch them take it. You get them set up. The social worker meets them. This is what we're doing in our ER. The social worker meets them, gets them set up the next morning in one of the clinics now. We have a couple in Bellevue that have openings. So it's not even like the 3-month wait that you hear from methadone clinics and things like that. If you get people into those Suboxone programs, their ability to stay opiate-free goes up like 5-fold. I mean, it's night and day different. And in fact, if it's a weekend or something, you could administer that dose now 3 times in a row. The patient comes back each day to get the dose to get them to Monday where they can get into the clinic for treatment. So we have a very comprehensive opiate work group. As Mike mentioned, we actually, and this is not an exaggeration, we have the lowest inappropriate, and there's actually a definition for that, inappropriate opioid prescribing rate in the state. We do extraordinarily well. Again, as I said, we approach it both from prevention side as well as the treatment side. And the treatment side is the one that I'm really excited about. This is really new in the last 6 to 9 months that we have this ability to do the therapy in the ER and then get people plugged straight into clinics.
Thank you, Doctor.
Yeah.
Do we have any other questions?
I just want to reflect back on your story about this woman and her daughter, and at discharging a patient is always a complicated, complex process. And I know from my knowledge about our hospital, we do have swing beds and here for those who are in need of those. But when a person might have to be discharged, is there a connection where the patient and caregiver, like a caregiver connection network, that we can tap into to know where those places that is suitable to be placed a particular patient,
But there are resources, and
and it's challenging, the discharge. You need to know where, like you said, you put them in a hospital, in a hotel because it was something that.
I can hit up.
Okay. Oh yeah, I was gonna either direct it to you.
So care management
Okay,
works for me as
thank
well.
you.
extraordinarily challenging. What we've done is tried to work with many of the facilities locally that, let's say, espouse to our values, again, which is making sure that the patient's getting appropriate treatment, that they're not just staying in there to hit their 100 days. And, you know, so we have 7 really good partners through EHN, through this Eastside Health Network, of facilities that work very closely with us. Snoqualmie obviously is a close partner and all that as well. And these are folks who are willing to share their data, willing to take part in quality forums. We actually get together and have 7 of these facilities get together. I'm not sure I got all the nuance of your question, but one of the biggest challenges, again, we have is folks who have no insurance. So this woman, again, is an example where, you know, our option was go back to the car with her dog and her daughter, or put her up in a hotel. And, you know, the right thing to do morally, ethically, was to put her up in the hotel and give her a chance to go through rehab. The other thing that we've done, and this is not that rare, and this goes back even to our comment about the ACA, we will go out and buy them an insurance plan on the market. And we've done that many times, where we say, you know what, this person's going to have some ongoing healthcare needs. If they don't have access because they don't have any insurance, they're going to come back in 3 months or 6 months and be, you know, have something catastrophic. And so through our care management team, we will go out and buy them like a bronze plan on our silver, typically a bronze plan on the market. And that gets them health care so that they can continue seeing a provider and get the care they need. So I want to make sure, though, that I touch.
Yeah, I think what I'm trying to express here is, let's say I'm a patient and you have to discharge me and I'm homeless. Is there a way for me to connect? Is there a connection, network connection where I can, you know, that
you
I
as
can...
a patient who's homeless?
Or anybody, or someone who has no family member and needs some referrals. And I want to do it on my own because I don't have anyone to help me.
That's a void.
It's a void, yeah.
So what some communities are doing, and we've had conversations with the Bellevue Fire Department, they're starting like community paramedicine programs. So you have so paramedics. One of the things paramedics, you know, struggle with are people who are using 911 system as essentially a I don't want to call it a social network, but a reason to connect with social services, non-emergency services, which then takes paramedics out of the capacity to care for true emergencies.
Right.
And so what some communities are doing is they're hiring MSW social workers, and they will have them. In fact, we have in Bellevue, we do have
discharge planner.
They call it, they don't call it paramedicine. They have a different name. It's, I want to say community connect or something, but it's a social worker. A couple that they bring social work students out of the University of Washington that go to individuals' homes that they know are medically fragile or that they know don't have a support system, and will check on them and will help manage their care in a way that prevents that care being managed by paramedics. So that's an example for someone who has a home. I can't say that for a person who doesn't have a home that is as well managed, but the east side is pretty progressive. I don't know that as much about the homeless situation this far east in the county, but in Bellevue we're making good progress on having a permanent homeless shelter for 100 men in Bellevue that will be year-round. Right now it's only during the winter months. Sophia's Way, which is, I think you probably know, is a project that's getting off the ground just up in Kirkland. It's where once people get a roof over their head, a lot of other things start to fall into place.
I think interesting, Mike, the paramedicine program, actually, I just heard like a month ago that they are actually trying to identify the typical locations of some of the homeless, and they're now actually literally they'll take the medic van out there in their free time and do blood pressure checks and welfare checks in sort of encampments or by the train tracks by the Burger King buyers. Literally, that's one of the most common places, and they will actually go park there and do checks on folks.
Gentlemen, I'd like to thank each of you for coming this evening. You have Mike, Rob, Andrew, David, and Jonathan. We appreciate your time. We appreciate you sharing with us and being really open. so much.
All right, thank you very much.
Thank you very much.
Appreciate it.
Thank you so much.